So I work for Uganda Blood Transfusion Service, and our mandate is to make sure that we have available, safe and adequate quantities of blood and blood products in the country for proper management of patients. And I emphasize on the word proper management of the patient. So blood and blood products are actually a very scarce resource, but very, very important in maximizing the patient outcomes. And it's the reason why we always emphasize to the prescribers or the transfusionists to always minimize the risk of transfusing blood itself and then the wastage. So it involves ensuring that blood transfusion are based on guidelines. You just don't get blood and give the patient anyhow without revisiting what the guidelines say, depending on the product that you are giving to the patient and the condition. It's the reason why we have to have this discussion. It is carried out in a very safe and efficient manner. Otherwise, if it is not safe, carried out safely, you are going to actually kill the patient. Now, since we know it is a very scarce resource, however, its transfusion should be very safe. But sometimes, in the event of saving somebody's life, if things go wrong, certain things cannot be saved. For example, transfusion can actually cause complications, either through adverse transfusion reactions or even getting transfusion transmissible infections. What are our objectives today? We want to understand the requirements of the appropriate utilization of blood. What do we need to appropriately use the blood we get from the production centers? We also want to understand the principles. In some guidelines, we actually prefer calling them the 10 commandments of blood transfusion practice. 10 commandments, just like the Christians follow the norms and the ethical guidelines in the Bible. Same with my Muslim brothers and sisters. In this perspective, we also want to understand what are those guidelines that we need, what are those things that we need to follow to ensure that the practice is actually safe for the patient. So I'm calling them 10 commandments of blood transfusion practice. However, in simple terms, it can be called the principles of appropriate utilization of blood. It's what we are going to discuss today. Then we also have to look at the risks and the mitigations and the blood product indications, and of course, describing a few characteristics of the different products we have available in UBTS. So what are some of the key factors? It is basically demand and the supply, accessibility of the adequate products that the patients need in your facilities, and then the supply of those very products. But once you're given those products, how do you use them appropriately? It is the basis of our discussion today. So what are those requirements that we need for appropriate utilization of blood? Do we have a national policy on clinical use of blood? If yes, what are some of the supportive regulations available? How about the commitment of the authorities, and then you, the healthcare providers, the clinicians, the blood prescribers? Are you committed to following these guidelines if they are made available to you? Do we have a nationally coordinated blood transfusion services or establishments? Yes. The country has, almost every region has a regional blood bank and collection centers, which I think it will be discussed in the subsequent presentation. So we have them in place. And the government of Uganda has made efforts to actually decentralize the services by creating more of these regional blood banks and collection centers. However, the other nitty-gritties can be handled at a later time. So if we already have the establishments in place, how about the promotion of the availability of simple alternatives? Do we all the time need to be transfusing our patients? The answer probably is no. Some cases actually don't need blood, and it's what we want to emphasize and preach the gospel to the prescribers that, please, before you go for the blood transfusion, try to exhaust other avenues, other alternatives like the crystalloids and the colloids, okay? Where need be, try to do the treatment. How about the pharmaceuticals? Do they have the drugs? If it is iron deficiency anemia, we don't need the blood transfusion.
Recording in progress.
You don't rush for that. But do you have the iron therapies available? If it is an open heart surgery, for example, do you have the tranexamic acid, the TXA, which is commonly used to reduce on the massive bleeding of the patients? Then finally, do we have the guidelines on the clinical use of blood in place? Do the prescribers actually use them as their aids? Do they move with them in their pockets to keep referring to, just in case they don't understand certain things? So those are some of the questions we need to start asking ourselves, and also interesting ourselves so that we improve the practice of blood transfusion in Uganda. Now, we know if blood is given when it is not needed, the patient doesn't benefit anything from it. In fact, the patient is exposed to unnecessary risk of getting HIV, hepatitis B, hepatitis C, all those transfusion transmissible infections, and the complications may be due to heart overload, what we would prefer call iron overload, or TACO or TRALI. All those complications can arise. And maybe if you unnecessarily give this blood, yet the patient doesn't need it, you are going to waste this product, yet there's another patient who is in dire need of this patient. So you're actually wasting resources as well. You're creating shortage by giving blood to a patient who doesn't need and leaving out the one who actually needs most, and also creating wastages of the resources. So we need to take care of some of these things in our practice. Now, what are these 10 commandments? But before I jump to the 10 commandments, we need to understand the process, what happens. This usually starts with the patient. The person who creates demand for blood is the patient in the ward. But the clinicians have to do proper assessment of the patient to actually make sure that they understand that this patient now needs blood. If the patient needs blood, yes. What do you have to bear in mind? Are you getting the right blood for that patient? Is it the right patient that you're going to be giving this blood to? What time are you going to give this blood to the patient? And where are you going to transfuse the patient? Because sometimes we have had cases where patients are actually transfused from home. But in case something happens at home, no one knows how it will be handled. So it is important to understand this holistically. Now, I can now go straight to commandment number 1. Blood transfusion should only be used when benefits outweigh risk. And there are no appropriate alternatives. You don't have these, you have not exhausted all the alternatives, but you are rushing to give blood. We are not saying that you don't give blood, but the emphasis here is critically assess the patient to actually ascertain that the patient really, really needs blood. If he doesn't, try to explore other options before rushing to blood. So the results, and this is another controversial, something happening in our facilities. Results of the lab test are not necessarily the sole deciding factor for transfusion. The HB is 7, because in the clinical guidelines, it is a transfusion trigger. For example, I'm just giving an example. This does not necessarily necessitate that you give the blood, because the lab test has given you HB of 7. There are other avenues that you can explore. Recently, I was training somewhere in one of the hospitals, and a nurse who works in that hospital says, sometimes my HB reduces to 7 and they transfuse me with the blood. Should I continue getting blood transfusion? After opening the eyes, I'm like, no, please stop that. So this can also be applied to the other regular patients we always get. Number 3, transfusion decisions should be based on the clinical assessment underpinned by evidence-based guidelines. You're comparing your clinical assessment with what the guidelines say. Sometimes a good doctor may deviate from the guidelines if he knows what he's doing, but it is also very risky to always deviate from what the guidelines say. So it is now trying to coordinate the two, assess clinically and then follow what the guidelines say. Number 4, not all anemic patients need transfusion. So there is no universal transfusion trigger, like I've mentioned previously. Even if the guidelines say, if it is open heart surgery, for example, and the trigger is HB of 8, it doesn't necessarily mean that you have to first make sure that blood is there. So you have to assess all these things. Supposing you try to use the devices, if the facility has the devices for reducing the overbleeding of blood, you don't necessarily need very many units to give that patient. So not all anemic patients need transfusion. Others actually need, some iron therapies, Others, you just tell them to go and eat food. You know, necessarily like this staff who is working well, and why do you transfuse? So you're wasting resources and also exposing the patient. Discuss the risks, benefits, and alternatives to transfusion with the patient and gain their consent. Unfortunately, in our practice, many of us don't do this. We are like the God. We are the God in the hospitals. The patient look at us as the alpha and omega. We don't even need to ask for their consent, and yet this is a requirement. Even on the request form, there is a provision for where the patient or the attendant should consent before accepting blood transfusion. Ideally, supposed to tell them that, well, this blood is going to save your life. However, if you don't get it, you might die. But if you get it, there are also risks that you might actually get HIV or hepatitis B. But many of us think when you discuss with them, you are going to scare them away and they will not get the blood transfusion. So, but it's good to have a consensus with them, a rapport with them, and then you give the blood. The next one is the reason for transfusion should be documented in the patient's clinical record. This is very informative, very, very informative. There are cases where a patient has received, for example, maybe basing on the clinical assessment or the situation at the time, the patient is rhesus negative and was given 1 unit of rhesus positive, and that is not documented anywhere. Yet, you know, at the back of your mind, should this patient get a second O positive or rhesus positive blood, there's going to be a transfusion reaction. This should be documented, and the patient is supposed, each time he's going to any hospital, should even be carrying. If there was a way of putting a tag on the face that I was once given a rhesus positive blood, wherever he goes to the hospital, they have to be referring to that. So it's very important to always document the patient's record in their book or the request form. Timely provision of blood components supporting major hemorrhage. Otherwise, we can request for blood and then maybe you take, if it is an emergency and you take over 3-4 hours, the patient can die because you did not respond in time. And sometimes even when the blood is there, you don't communicate in time. It doesn't cost anything, okay, some small money to coordinate between the ward and the lab and just asking on phone, do you have this blood? If they don't have, then they can try to mobilize how to get the unit from wherever they can get to save the patient. Commandment number 8, failure to check patient's identity can be fatal. Patients must wear an ID band or something that should be used to identify the unique patients, their name, date of birth, something. Now, ladies and gentlemen, I can give you an example of something that happened in one of the hospitals in this country. Because of poor identification of the patient, a very normal person who never needed a blood transfusion was forcefully transfused in one of those hospitals because of mislabeling and identification of patients. So it may sound something simple, but this is very, very critical. And the patient was trying to resist that. No, I don't need blood. But because the Musao is always the alpha and omega, they forcefully gave the fellow blood unnecessarily, and yet he did not need it. Fortunately, he did not die. There was no heart overload anyway, because it was just 1 unit of blood. So in case you discover that there is some bit of discrepancy, please do not transfuse that blood. Immediately call the lab and then you rectify the identity. Number 9, the patient must be monitored during transfusion. I don't know how many facilities do this bedside monitoring. We have developed tools to do this. And in some cases, we also see the records being written in the exercise book and all that. But honestly speaking, this bit of monitoring of the patient is not done appropriately at the bedside. And yet, the ideal thing is, before you start the transfusion, take the vitals of the patient. Before you can connect the IV line, but please do not connect the blood yet before taking the vitals. And this will help you to understand or to establish any deviation from normal. Then after 15 minutes, please do the vitals again. After 30 minutes, do the vitals again. After 1 hour, I know this is not feasible, but at least in the first few minutes, it is very important, very critical for the safety of the patient. Sometimes the transfusion reaction that we get are not necessarily a result of neglect by the nurse or whoever is attending to the patient. Sometimes the problem is actually on the blood itself. The problem might be on the blood itself. the problem might be on the patient, not necessarily the health worker who is managing the patient. So it is important to always make sure you monitor the patient, and also in case there is an adverse reaction, you record immediately. This will help in the investigation of the adverse transfusion reaction. And finally, what I am doing now is part of the 10 commandments: education, training, underpin the safe blood transfusion. And we should always embrace this in our facilities regularly in form of CPDs. If for example, you have 2 CPDs in a month or 1, at least ensure that you slot in blood transfusion. Some of the things that we are talking about now, we are not taught in universities. So it is good to always keep updating ourselves with the latest information, latest research, latest science that underpins the practice. So what I'm exactly doing now is part of the 10 commandments, which is, I put it as the last, which we should actually embrace and be doing frequently. So what are the risks then of blood transfusion? The first primary one is the immunologic reactions. We have seen these allergic reactions, and sometimes is febrile non-hemolytic reaction, chills and whatnot. So you may not have a say in this. It happens. Then it's the problem is coming from the blood itself. Maybe the antibodies are reacting with the antigens, and the patient experiences some chills. Then there is this one, which can actually kill, hemolytic transfusion reaction, or hemolytic transfusion reaction, especially the acute. And this is always brought about by ABO incompatibility, where a patient is given wrong blood. A patient of blood group O is given blood group A, for example. Some few mils or volumes will end up killing this patient, and others might be delayed, but this acute one is what has killed very many of our patients when the wrong blood group is given. So imagine, instead of avoiding blood transfusion, you are risking the patient by giving blood. And should the compatibility test not be done on that, which some facilities actually don't do, by the way, they'll be like, okay, blood bank, they are perfect. They have put the sticker of blood group A or some, whatever the case may be. And they don't go ahead to do the regrouping of this mother bag. And yet there can be an error, and it is a wrong sticker which is put on that unit. So you just pick it as O because you've learned in school that O is a universal donor. And then you make a mistake and kill someone as a result of the hemolytic reaction because you've given a wrong blood group. Infections, transfusion transmissible infections. This is something that we have to discuss with our patients even before giving them blood. If they agree to it, because of course you say UBTS has the safest, has the technology that can make sure blood is very safe. They screen using very robust technologies, yes. But there is this 1% or 0.1% of chance of you getting infected with hepatitis B or C. But by and large, it is safe. Can we go ahead and give it? Then it's okay, fine. If he says, I am worried of that 1%, then you discuss with the patient, and he can even decline, and you note it down. There is also fluid overload, which is TACO, iron overload, TRALI. How do we mitigate these risks? How do we mitigate this risk? At the production level, we ensure that we select our donors carefully by screening the donors first, asking those, some people say funny questions, but we ask those funny questions for very good reasons. So it is part of the donor screening. And we also use very sophisticated machines to do the testing of these TTIs. So that is at a production level. How about adhering to the guidelines? Who is supposed to be enforcing this? And if you are told today that, okay, OKELLO came for support supervision, he told us we should be following this and this and that and that. Do we have the continuity of that message? Do we have the hospital transfusion committees to actually emphasize on the adherence to guidelines? Patient monitoring, I've already mentioned. Alternatives to transfusion using blood conservation techniques, like some facilities may have machines that can actually try to preserve, not to avoid overbleeding, and also giving some drugs that may stop the overbleeding. Now, which are the components? Which are the components available in UBTS? I want to begin with the cellular parts first. We have readily available the packed cells, we have platelets, which sometimes we call platelets-rich plasma. And the practice of leukocytes was abandoned many years back for the reason of white blood cells carrying human leukocyte antigens. But somehow, because of the advancement in technology and science, like in the recent conference we attended, meeting we attended, there is a way we can actually kill or destroy or deactivate these human leukocyte antigens, and white blood cells can still be transfused to cater for the patients who have those stubborn bacteremia that are not healing, sepsis, which are not healing. They are not listening to any antibiotics. So you can only help the patient by giving more of the white blood cells to engulf the bacteria. So the practice might come back now that the technology of deactivating the human leukocyte antigen or even the cytomegalovirus, which are all carried by the white blood cell. So otherwise, those were the reasons why the practice of leukocytes were abandoned at some point. We also have fresh frozen plasma readily available. And what puzzles many of us at the production level is that many of our clinicians don't even request for these fresh frozen plasma, yet we have them in plenty. Maybe because they don't know, maybe they want some more information on the indications, which we'll discuss at a later time. Even there is fresh plasma. We sometimes call this liquid plasma. This is the plasma which is prepared from freshly drawn blood or donated blood, which has not exceeded more than 6 or 8 hours. So we can actually prepare this, and if the patient needs urgently, we don't take for freezing. We just prepare them and immediately take for the patients to receive them. We don't freeze them. Then we also have cryoprecipitated. Ladies and gentlemen, for the few who have visited us, especially the oncologists, some doctors who have come to our place, they have appreciated the practice of giving their patients the cryoprecipitate. Sometimes you get bleeding from children whom you cannot tell what is causing the bleeding. You are giving fresh frozen plasma, they are not stopping. Not until they give cryoprecipitate, and that's when they start responding. Okay, so it's good to have an understanding of some of these products, which we actually have them in plenty. Now, I have put this slide for us to appreciate our blood donors. That from one single donation that donor gives for free, we can prepare very many different products to save the lives of very many patients. We can have our pack cells, we can have our platelets, we can have our plasma, we can have all those, even cryoprecipitate from the same donation. So meaning, we don't play around with the treasured product that our donors give. But in a similar way, you can also get infected from any of these products for as long as the screening is not done properly. I don't want to talk about the other aspects of some facilities deriving their mechanisms of screening for the blood by themselves using strips, which might, to my understanding, is very risky. So try to avoid that. Now, why should we embrace the specific products anyway? First, we want to conserve the resources and minimize wastage. We want to actually reduce the risk of circulatory overload. We also want to give the benefits of these products to our patients directly, because a concentrated form of the required fraction can be administered and you actually see the impact as soon as possible. You don't have to wait for many days to see the impact, as long as you have given a concentrated platelets, for example. Then from one single unit, you can give very many patients different products. That's why we have to embrace the specific products. Now, this brings me to this point, that sometimes when we are making requisition from our facilities to the blood banks, we put very many units of all blood, and then blood bank tells you, we are giving you pack cells mostly. That is what is happening now. And the reason is, in our procurement plan, for example, we have given requested for more quadruple bags than the single bags, so that we can prepare the different products from the quadruple bags. That's the reason why when you don't give you enough whole blood, please don't be offended. Don't start throwing stones at us. We're also trying to take you now to the specific products, that if you want, what do you want from whole blood? And if it is the plasma, we have the plasma we can give you. If it is the red cells, we have the pack cells we can give you. So it's just an information that you need to take home, that most of our products now are pack cells. Not until we get, again, more bags for single units that can eventually give us the whole blood. So, like I said, we have very many regional blood banks across the country and collection centers across the country. But I want to give you this information that whenever you go to a collection center, please do not expect to get platelets there. Do not expect to get fresh frozen plasma there. Do not expect to get cryoprecipitate there, or even the fresh plasma. At least you will be able to get whole blood and packed cells readily available. The reason is collection centers do not really have the equipment to prepare some of these products. They don't have the equipment to prepare platelets or FFP. So don't ask for these other products. If the patient needs them, coordinate with them so that they can get from a regional blood bank, a nearby regional blood bank. However, in all regional blood banks, we have whole blood, packed cells, platelets, FFP, cryoprecipitate, and even the fresh plasma. They can give you, but not collection centers. So let's briefly discuss the clinical transfusion process. And we're saying it all starts with the patient who creates the demand for blood. And before the patient receives blood, the clinician has to assess the patient properly to decide on when to transfuse the patient, whether to transfuse the patient, when to transfuse the patient or not. If there are alternatives, okay, for this patient, based on my assessment, let's first give iron therapies. After all, it is just iron deficiency anemia. We can treat this, okay? Then, if the patient really needs blood, based on the clinical assessment and comparing it with what is in the clinical guidelines, please order for the blood components. Choose the right component. This is again where we go wrong. We just order, the patient is, okay, iron deficiency case, but you are requesting for whole blood. For what reason? Yet you can get packed cells. Request for packed cells. If packed cells are not there, let the blood bank give you whole blood when they don't have the packed cells, okay? Then, after making your requisition, the number of units you want, the product you want, then the samples should be taken to the lab for pre-transfusion testing. Again, these steps should not be missed out. Ladies and gentlemen, this is where we get issues of giving wrong blood groups to patients and end up dying or getting adverse transfusion reactions. Once the compatibility is done, I mean the real blood compatibility or cross-match, not this tile thing that we do. I have never learned about tile in any school anywhere, but now it is the common practice. We don't call that compatibility really. So once that is already done, deliver the product or deliver the blood components to the ward. And here the patient can, the doctor can come for the blood himself or herself, or the nurse can come with these clean, they used to use petri dish or clean trays with a towel, not a towel, maybe if they have paper towels or something clean to deliver to the ward. Now, once it is delivered to the ward, the administration of the blood has to be done from the ward. This is again where there is a missing link. The patient is not prepared. Blood is delivered to the ward. Blood stays for over 1 hour on the bench. The transfusion is not started, but is packed cells or whole blood is left on the bench for over 30 minutes. Let's use the standard, over 30 minutes, not connected. This is dangerous for the patient. And once the administration is being done, please, again, try to ensure that you do the bedside monitoring of the patient. Now, I do not want to discuss these transfusion triggers for the reasons I have discussed already, that there is no universal transfusion trigger. However, you can usually follow what is in the clinical guidelines. But what we know is that 1 unit of whole blood or even the packed cells should increase the HB by about 1 grams per deciliter in an adult, or the hematocrit by about 3%. But you have to understand the nitty-gritties in deciding whether to give the patient blood. For example, if it is a patient undergoing cardiovascular surgery, the HB of 9 should not, you can actually decide to say, this is an open heart surgery. Even if the HB is 9, I'm going to proceed and do the surgery. So it is already deviating from what is in the clinical guidelines. But this is still okay. Now, let's look at the suggested transfusion rates. This is about how long should the blood transfusion take. For whole blood, we recommend, the guidelines recommend between 150 to 200 mils per hour. But our unit is usually about 450 mils. So from this narrative, you realize that transfusion should be completed within 4 hours, should not exceed 4 hours, and can be at a rate of about 2.2 to 5 mils per kilogram per hour. This calculation may be tricky for some people, but there is a way you can adjust. And for packed cells between 100 to 150 mils per hour, platelets about 1 to 2 mils. So platelets within 30 minutes, it's done. You don't need to wait for that long. Within 30 minutes, it's done. After all, the volume is just very little, between 50 to 70. Now, this is the same duration I was talking about. Like, should you remove blood from the lab out of the fridge and your ward does not have a fridge, please do not allow blood to stay on the bench for over 30 minutes without refrigeration. If it happens, please take that blood back to the lab where there is a fridge. In fact, this blood should even be discarded. It should be discarded. But sometimes we leave them for 40 minutes, even an hour before connecting, before starting the transfusion. Like I said previously, stop the transfusion within, should not go beyond 4 hours. How about platelets? Before you make requisition for platelets from the lab, if they have an agitator, make sure the IV line is already connected, it's already in place. The IV line is already in place, and the IV line already in place should now help you to actually make sure you do the transfusion within 30 minutes. FFP, same. But the issue with FFP is that sometimes it needs thawing. Many of our facilities do not have the incubators or the machine for thawing the platelets. Thawing is making the already solidified plasma to become liquid. Liquefying it is the process we're calling thawing. So in most cases, they remove from the lab and then put it on the bench. That will take about maybe an hour or so. But as soon as it has become liquid, please make sure you transfuse the FFP within the 30 minutes. Same with the cryoprecipitate. But most importantly, the platelets, ladies and gentlemen. We do not give a chance to platelets to sit in one place on the bench, because platelets will aggregate together and then they will form clumps. So whatever you'll be transfusing within those 30 minutes will just be plasma. You will not get the platelets there. So you'll not achieve the objective of transfusing the platelets. So it is a requirement that the facilities that request frequent requests for platelets like Cancer Institute and other facilities must have the agitators. So the agitators will help to make the platelets agitate 24/7 continuously. Now, let's look at the general indications for blood transfusion. Why do we even give blood transfusion anyway? The primary goal for packed cells is actually to increase the oxygen carrying capacity of blood. I mean, oxygen carrying capacity to the carrying oxygen to the rest of the tissues. And then to restore the blood volume. And this is usually only for, trauma cases and also effective tissue perfusion. I will give you the indications, specific indications, and also to replace the platelets, coagulation factors, and other plasma proteins. So, ladies and gentlemen, for the case of FFP, FFP is our broad spectrum in terms of the coagulation factor. They have almost all those coagulation, including the heat labile factors, for as long as after the preparation, they are frozen immediately. So, in some cases, you do not need to hassle so much in beating your head on how to stop the bleeding, and yet you have the fresh frozen. You don't know what is causing the bleeding. Is it a deficiency of the coagulation factor? If you don't know it and your facility does not run the coagulation profile, just give FFP. It's a broad spectrum. Now, let's go straight to the specific characteristics of these different products. We have all blood that, forgive me for that naked hand there without the glove. Safety is not guaranteed. Forgive me for that picture. But that is all blood. That's how it looks like after settling for some times. And I want to go straight to why we give all blood. Indication number one, which to me is the most important one, is exchange transfusion in neonates, ladies and gentlemen. And this exchange transfusion in neonates should be from fresh blood. Should be from fresh blood. All blood, but fresh in neonates. In the event that we don't give you packed cells, please happily use all blood. But the reason here is, if it is iron deficiency anemia that you want to correct, you may not achieve the goal or the objective compared to when you use the packed cells. But because you do not give you the packed cells, please go ahead and transfuse whole blood, bearing in mind the circulatory overload because of the plasma, which we did not remove from there. Open heart surgery is where we commonly use whole blood. Open heart surgery, patient on heart-lung machine, usually whole blood. And massive transfusion to correct hypothalamic shock, especially during accident cases. Why do we actually prefer using whole blood during accident cases or trauma? Because we are not only considering boosting the red cells or the hemoglobin per se, we are also correcting the blood volume. Because with the maybe profuse bleeding, in most cases, the patients tend to have hypovolemia. They get into hypothalamic shock. The blood pressure starts lowering. And in your physiology, you realize that for you to increase or to boost the blood pressure of the patient, you need to boost the what? The blood volume. But, like I said, must you run for blood to boost this? We have the IV fluids. Instead of rushing for blood, first do the IV fluids to boost the what? The blood pressure. So what is the advantage of giving whole blood? If it is very fresh, yes, you will still get the other components like platelets. You get some of the heat labile factors still in the plasma if the blood is fresh, okay? You will get all the other issues, all the other components. But the disadvantage here is that the risk for blood volume overload or the potential transfusion reactions. And remember, the antibodies are there. Sometimes because we did not prepare, remove and we don't filter the blood units, the blood we get. So we transfuse with the white blood cells. And I mentioned before that white blood cells are also responsible for some percentage of transfusion reactions because of the human leukocyte antigens. So what about the contraindications? Conditions where volume overload is a risk. Please don't give whole blood. Patients with chronic anemia, don't waste whole blood. Go straight to packed cells because they're just correcting anemia anyway. And that is when you've decided to transfusion anyway. You've exhausted all the other options and they are not working. Then you can actually say, okay, let's give packed cells. Whole blood rather. How about packed cells? This is between 100 to 200 mils. And we expect the concentration to be approximately 20 grams per 100 mils, not less than 45 grams per unit. And the specific indications, number one is acute blood loss due to trauma. Like I was saying, in the event that you don't have whole blood, you can still give your packed cells as long as you have the IV fluids to do the plasma replacement or the plasma volume replacement. IV fluids will do the needful, and then you boost the oxygen carrying capacity of the patient by giving the packed cells. GI bleeding, chronic anemia, unresponsive to treatment. You've tried your iron therapies, they are not working. You've tried, exhausted the other options, they are not working. Please go for packed cells. Hemoglobin level below the critical threshold. Again, this is very subjective, ladies and gentlemen. The threshold for a sickler, okay, the threshold in the clinical guidelines might be 5, for example. But there is a sickler who is working and doing very well at HBO, using HBO 4. So it is very subjective. So like I said, you go back to clinical assessment before you rush for blood. Perioperative management. Now, this perioperative management, this is the chain of management right before the surgery, during the surgery, and after the surgery. Bone marrow suppression, hemolytic anemia, cardiac CVD. What about the advantage of packed cells? Efficiently supplying your oxygen to the rest of the tissues without much problem. But there is also a risk of volume overload. But the disadvantage here is that does not provide platelets or clotting factors when it is fresh, even when it is fresh. Contraindications, patients with compensated anemia. Now, there are categories of patients. Let me explain this. There are categories of patients whose bodies have adapted to very low levels of red blood cells and even hemoglobin. And they are still perfectly carrying the oxygen, delivering the oxygen to the rest of the tissues. A case in point is some of the sicklers. You might look at the HB after doing your CBC and like, oh, the HB is very low, but the fellow is performing very well. So if you go ahead and pump that person with the blood, you might actually cause overload. and bring problems to the patient. So there are mechanisms of patients with compensated anemia. I'm going to give you the explanation. Iron overload, volume overload, trolley. Now, how is the compensation done? The increased cardiac output, because the body gotten used, like has adapted to lower red cell and hemoglobin, the cardiac output increases. The heart pumps more blood to compensate and then deliver blood to the rest of the tissues. There is also redistribution of blood flow to the most important tissues or organs like the heart and the brain. The blood doesn't need to go to the tissues of the cabina, of the buttocks or the skin. It's not very important there, but they are redirected to the most important organs like the brains and the heart. There's also increased oxygen extraction by the tissues, okay? And this is done by what is called the oxygen dissociation curve, which I've already mentioned here, that is also increased production of 2,3-diphosphoroglycerate, which primarily affects the oxygen dissociation curve. Increase erythropoiesis to compensate the red cell production. You know, you get very little, but I mean, the bone marrow has to be activated to produce more of the red blood cells to compensate. There are conditions that cause all this. Sometimes people from very high altitudes come down and then you do their HB and low, the HB is low. The fellow will compensate. There is no need for transfusion there. Platelets, ladies and gentlemen, is what we usually give you is between 50 to 70 mils. Very small volume, but it's concentrated, okay? And the dose usually, I did not want to put this, but still it's okay. You consider the kilograms of the weight, but there is what we call the pooled platelets, where you collect maybe 4 to 6 single units of platelets into one bag. We don't have those bags in Uganda because they're expensive. So you can collect those simple small ones, 4, 5, 6 of them in one bag, and we call that pooled platelets. But in Uganda, we're giving this single small units of platelets, which is between 50 to 70 mils. When and why do we use platelets? Thrombocytopenia. But what has caused the thrombocytopenia, ladies and gentlemen? Not every thrombocytopenia will need platelets transfusion, okay? Not every, but we are talking about this in regard to chemotherapy, okay? Active bleeding, if there is severe or surgical invasive procedures. And sometimes maybe drug-induced platelet dysfunction, we give platelets. Massive transfusion with dilutional thrombocytopenia. The patient got an accident, you ask for whole blood, you started doing your massive transfusion, you are actually diluting the number of platelets or the concentration of platelets in the patient. So when you do your CBC, you will get very low count of platelets, and thrombocytopenia will appear. They know, okay, what has caused this? Because of the massive transfusion. DIC is the next point. ITP, papura, marrow transplant, myelodysplastic thrombocytopenia. All these are fact, but the most important point here is, as clinicians or practitioners, look for the cause of the thrombocytopenia. For example, we have seen cases where a patient gets sick of malaria, comes and they do CBC, you will see thrombocytopenia. Must you transfuse that patient with platelets? The answer is no. Treat the malaria, don't waste the blood. Treat the malaria and the things will normalize. So the advantage here is that, yeah, the impact is very, very immediate. You don't have to wait for 4 or 5 days to get the impact. It's very immediate, but unfortunately, the shelf life of platelets is very, very, very low. 5 days, they are already expired. So that's the problem with it. And the contraindications, platelets transfusion refractoriness. Now, this is a condition where the patient is not to it can be immunologic or non-immunologic. You're giving platelets, is not responding. Giving platelets, not responding. Must you continue to do that? No. And sometimes it can be caused by, the refractoriness can be caused by infections. So you have to discover why the platelets are not working. Is it the platelets which are non-functional or something continuously destroying the platelets in the system? And then Conditions where platelets count is sufficient or recover. Given an example for malaria infections. Please do not waste platelets on thrombocytopenia caused by malaria infection. Fresh frozen plasma, my broad spectrum. My broad spectrum. You know, you're giving fresh frozen plasma to sort out DIC deficiencies of all those coagulation factors, including the heat labile ones, by the way, because we prepare these things from fresh blood. So, what are some of those indications? Vitamin K deficiency, warfarin reversal, if the patient is bleeding. You know, sometimes there are patients who have issues with the blood clot, and then they put them on blood thinning therapies, like warfarin, for example. Unfortunately, if they get a cut, some of them tend to bleed profusely, to overbleed. And now that means the effect of the warfarin is what is causing the overbleeding. And then you have to reverse this effect. So how do you reverse it? Must you again go for maybe medicine or whatnot? Please give FFP. It will reverse the effect of warfarin. Burns, irrespective of the degree of burns. Then acute DIC. DIC can be, platelets can be given for DIC. FFP can also be given for DIC. In case you want to correct the deficiency of any clotting factor, please go ahead and happily give fresh frozen plasma. How about cryoprecipitate? This is primarily used to treat hemophilia A. And interestingly, in Uganda, we have a group of hemophilia A patients, by the way. Okay? So the fibrinogen that we prepare in UBTS has a very large amount of fibrinogen, which is factor 1 and factor 8. So when you are transfusing fibrinogen, know that you're giving much of the factor 8, which is responsible for treating the hemophilia A and also fibrinogen. Because of the high molecular weight, when we centrifuge them, they will settle at the bottom. And then you can harvest. Maybe it's very small volume, but it's the impact is real. We have seen it doing miracles in our kids. Now, ladies and gentlemen, I want to summarize my presentation, by giving you a brief summary of the patient blood management versus the appropriate utilization of the blood and blood products. In the patient blood management, in the first place, we are doing whatever it takes to make sure that the patient doesn't reach a point of receiving blood in the first place. But in the event that all your interventions have failed, then please go ahead and give blood. So that's where the difference is. Now, when you are giving blood, you must make sure that you give the blood efficiently, which will eventually give a positive outcome. What are we focusing on? For patient blood management, for patient blood management, we are focusing on optimizing and preserving the patient's own blood. If it means removing your own blood and keeping it, then you get transfused later on. It is still okay, as long as you don't get blood transfusion from another source. If it means doing whatever it takes, giving you treatment before, please do it before getting the blood transfusion. Now, if the decision is made that you have to get transfused, then you adhere to the clinical guidelines for transfusion. That's where the difference is. Now, the goal of patient blood management is to minimize the need for transfusions and improve patient outcomes. Should this fail, please do it safely and effectively. How about the strategies we are using? For patient blood management, it is about the preoperative optimization. What is happening before the blood is actually given to the patient? Conserving it in whatever way you can, using whichever machine you can. But for appropriate blood transfusion utilization, please follow the indications. Why are you giving the patient that blood? Are you going to minimize wastage? Is it the right product to give to that patient? That is where the appropriate utilization comes. Anemia management. I have said this before. Please look for the type of anemia that is caused. Look for what is causing the anemia. Is it iron deficiency? Is it nutrition related? Is it medication or any other treatment? If it is so, stop the treatment if it is medication. If it is nutrition, please send the team from Ministry of Health or the nutrition unit to go and intervene before jumping to giving blood or transfusing the patient. But should all that fail, then primarily address the anemia through transfusion when it is indicated. And then the conservation techniques. There are techniques like cell salvage machines, controlled hypertension, all of them are there. But if you don't have, like in many of our facilities, focus on appropriate use rather than conserving techniques. And then audit and review, continuously doing the assessment, making sure that whatever you have in plan has been followed, regular audits for reviews and all that is in place, compliance is in place, they are following the guidelines. And finally, the safety of the efficiency and efficacy. The patient blood management is looking at the overall patient safety and health, reducing the transfusion. You don't want the patient to be receiving blood. But should those things fail, please make sure they are safe. Patient blood management involves multidisciplinary collaboration. Sometimes in appropriate utilization of blood, it's only the clinicians primarily responsible for choosing the right blood to determine that this patient now needs blood. So it is solely him. But for patient blood management, key stakeholders have to be involved before the patient is given blood. And of course, everything should be centered. The strategies including the patient needs and conditions. But should all those fail again, emphasis must be put on correct use of products for specific clinical situations. Then finally, the wastage, ladies and gentlemen. You realize that in our wards or wherever we practice from, we have wasted a lot of blood unnecessarily, given to patients who actually do not need blood, exposing them to TTIs. Can we try to reduce on this? Can we educate our clinicians? Can we have a platform where the transfusion committees can have meetings regularly to try to enforce some of this, to change the practice? Otherwise, you can get all these resources from the WHO guidelines. There are quite many online. Thank you very much, ladies and gentlemen, for listening to me.
Thank you so much, our great speaker, Sam OKELLO. Participants online, I think you've heard, this is a great presentation from Sam, enriched, full of information. We would wish to assure you that we will be sharing these slides for your review later via email and also via the Umlta